Good morning and welcome. We have two talks from PhD students from NCAS today. The first one will be Lesley Hawes, and she'll be talking about reducing antibiotic prescribing in general practice. Thank you, Lesley.
Thank you, Rod. Okay, we're right there. Sorry, just waiting to make sure everything's working. Okay, thank you everyone. I'm Lesley Hawes. I'm from the Department of General Practice at Monash University. I'm a PhD fellow with NCAS, and my supervisors are Professor Danielle Matzer from Monash and Associate Professor Kirsty Busing from here at NCAS. In today's presentation, I'm going to very briefly look at current general practice antibiotic prescribing rates, that we have an imperative to act on those. There are some strategies to reduce prescribing that are evidence-based, and I'm going to have a very quick look at 3 countries' resources and focus on 2 immediately accessible tools that GPs could use today in their surgery if they wanted to start reducing antibiotic prescribing. And then I'll summarise looking at the strengths and the gaps. So, you're probably all aware 46% of the population takes antibiotics in any year, and that's above the OECD average. Although that includes all sectors, we know the bulk of prescribing is from the community. Comparing us to European countries, we're the 8th highest, if we were in Europe, user of antibiotics, and our prescribing rate is double that of several North European countries. They've been doing antimicrobial stewardship a lot longer than us though. In Australia, we know that 60% of people with an acute respiratory tract infections get antibiotics, and we know most upper respiratory tract infections are viral or self-limiting bacterial. And it is causing us a problem in that most of the resistant Staph aureus infections, or MRSA, bloodstream infections are now community acquired. So we have an imperative to improve our antibiotic prescribing. We have Australia's first national antimicrobial resistance strategy, and Objective 2 tells us that we must implement effective antimicrobial stewardship practices across human health to ensure the appropriate and judicious prescribing of antimicrobials. So why do GPs prescribe antibiotics? Well, of course, to treat bacterial infections. But there's a fairly large group of patients where the diagnosis is less certain. Is it a bacterial infection or not? And then we also, with our ageing cohort and again more increased comorbidities, is bacterial infection a risk in my patient? And then we have to acknowledge there is patient pressure for antibiotics, both real and perceived by the GP that interacts with that. There are evidence-based strategies to reduce antibiotic prescribing. We have already things like regulations such as fluoroquinolones. We have accreditation. Most general practices are accredited to the RACGP standards. We have antibiotic prescribing guidelines in the form of our therapeutic guidelines. Other strategies include things like audit and feedback have shown to be very effective. Increasing communication with patients would certainly help with those in diagnostic uncertainty or where there could be perceived pressure for antibiotics. There are lots of tools and technologies available, such as rapid diagnostics, decision support, and of course, education. What I'm going to concentrate on today is audit and feedback of antibiotic prescribing and communication with patients. So audit and feedback is important to let the GP know where they stand with their own prescribing, and communication with patients, particularly for those more difficult cases. I'm going to look at resources from our own Australian government sites and compare and contrast with those from the United Kingdom on their Royal College of General Practitioners site, and America, the CDC site. I've chosen those as they are English-speaking countries who've been doing antimicrobial stewardship in the community for a bit longer than we have. I'm going to assess them. I'm going to have a quick look at the website, the general information and the ease of use. The audit information, I'll look at what tools are available. Does the audit give them feedback and compare comparisons. And with the patient leaflets, I'm going to look, are they available in other languages? Does it include things like the duration of illness, what to expect during that illness, self-management strategies for the patient, and of course safety netting, very important. Under what conditions should a patient return, particularly if they're not given antibiotics or a delayed prescription? And then how were these resources developed? Are they reviewed? And have they got any endorsements? First of all, our Australian site. We have a new site that was rolled out last year, 2017. And from the front page, it has icons that you can click on, and there is a general practice one, and this takes you to this page here for general practice. On the front page, there are 6 things under what you can do, simple strategies to get started on antimicrobial stewardship. However, I'm going to go to the right-hand side. You can see there are some other boxes. The middle one is antimicrobial stewardship. If you click on that one, it takes you to a page with a long list of links. And I've gone straight from that page, the links to the patient decision aids, and it takes you to the patient leaflets available from the Australian Commission on Safety and Quality in Healthcare. They developed and rolled out last year 3 patient decision aids. You can see at the bottom of the page there. One for sore throat, acute bronchitis, and the other one is middle ear infections. I'm going to look now at the sore throat one, and this is it. So it's titled Sore Throat, Should I Take Antibiotics? It does include how long the symptoms last. At the top here it says symptoms will usually get better in 2 to 7 days without taking antibiotics. Then it goes through just a bit further down that front page on the left. What are the likely benefits and risks of each option? The average reduction in time with a sore throat with antibiotics, it gives you 16 hours reduction, but however, without antibiotics, it lasts 79 hours. So the benefit for antibiotics is not huge. And at the bottom, there are 2 charts that show you the possible benefits. If you take antibiotics, 6 patients will be better by 3 days with antibiotics, but on the right-hand side with the right dots, you can see that 7 patients will have symptoms like diarrhea and vomiting. So that's something that the GP can discuss with the patient. I must emphasise that these sheets are not a parting gift to give to the patient. They are designed to be worked through in the consultation. So they would be particularly useful where the patient might be demanding antibiotics to help reassure a patient. On the reverse of the sheet, moving to the right-hand side now, you can see it does include self-management under are there other things I can do to manage a sore throat. It has the safety netting. When should you see a doctor and get further help? And there's a list of red flag symptoms that the patient should look out for. Right at the bottom on the reverse, there are some references. There are 2 systematic reviews that we used to develop this leaflet. It has a review date and a date for it to be revised. So it is evidence-based and reviewed. Going back to the Australian government site, there are other links to the NPS, which also has patient information on their site as well. However, this is not in the form of a downloadable sheet. This is online information directly accessible by patients. So I thought this one would probably be more of use for the GP to recommend the patient look this up when they get home. This website includes self-management, including for young children and when breastfeeding, which I haven't seen anywhere else. It does include safety netting, it includes duration of illness, it includes information on what to expect, which wasn't on any of the other resources, either the previous ones or ones coming, but it is only available in English. Then again, from the links on the government site, there's another one that takes you to the NPS audits. So looking at their audit information, they have 2 types of audit. On the right-hand side in the red box is Medicine Insight, which is the one I spoke about last December's Journal Club. It's a national practice level audit of electronic medical records where they're de-identified, downloaded and analysed by NPS, and they provide the practice with feedback and peer comparisons, but it's all medications. It's not just antibiotics. On the left-hand side in the box is the CPD, Continuous Professional Development. This is a GP level audit. It's a clinical e-audit, so the GP does it online, and they select 10 patients with a range of upper respiratory tract or respiratory tract infections, as you can see. So it is self-selected patients, and NPS promises immediate feedback and comparisons with peers. So in summary, the Australian government site is a new one. It has all Australian resources. It is fairly extensive. I've only given the very briefest glimpse at a couple of the links. The links to the Australian Commission on Quality and Safety in Healthcare patient information leaflets. They were the only ones that covered benefits and harms of antibiotics. They included safety netting, duration of illness, self-management, again, English only 3 respiratory tract infections, but they are referenced with dates for review. The site also linked to the NPS and, of course, choosing wisely and many other links with many clicks to get there. The NPS gave audit and feedback at 2 different levels, practice and GP, and both gave feedback and peer comparisons. The GP level, unfortunately, only self-selected patients, so there could be some scope for self-selection. The online patient info on the NPS site was quite thorough. It included all of the criteria I was looking at, but again, English only, and it was referenced as well. So moving on now to the United Kingdom, what they call their Target Toolkit. Target stands for Treat Antibiotics Responsibly, Guidance, Education and Tools. This website's been going for probably 9 or 10 years, or not the website, but this project has been going for 9 or nearly 10 years now. And it's all on the one page. So this is the front page, and you can see down at the bottom, there are a list of strategies with plus signs. This is the full list of all of their strategies. And I'm only going to look at 2 of them today, the leaflets to share with patients and the audit toolkits. So clicking on the plus sign for the leaflets, it drops down and you can see straight away what their leaflets look like and what they are. So it drops down, the top one is actually urinary tract infections, but when you scroll down, you find the respiratory tract infection leaflet. And I even searched a bit more and found there were some instructions which I've edited slightly to show you what they have. So they have room for the patient name so that you can personalise it for your patient. And it does give the information about the duration of illness. It includes self-management information. It includes the safety netting information. It even has a little section on what to do with leftovers. Now, this instructional leaflet is an older one. This is one from November 2017. There has been a new update, August 2018, that does not have those logos at the bottom. So it doesn't carry the endorsements. So in summary, it's available in 18 languages. There is also an additional pictorial leaflet. It does contain words, but I thought it could well be useful in a consultation where you're having, say, a phone interpreter for one of the other non-18 languages. Could be useful that way. It does contain simple words. So I guess you could call that 19 languages. They all include information on the duration of illness, self-management, safety netting. Like our Australian one, they are not a parting gift. They are designed to be worked through with the patient. They are all referenced. There is a flowchart that shows the development, all available on that Target website. There were no endorsements on the latest leaflet as such, but they have dates published and reviewed. So they do seem to be evidence-based. Their target audit was only for 4 respiratory tract infections, but there was an additional one for urinary tract infection. So clicking on the sore throat one, it's a paper-based one. It's 4 pages long. Page 1 is the antibiotic guidelines, which are the UK ones that don't necessarily, they're not necessarily the same as the Australian ones, and it had the instructions. Page 2 was a data collection sheet. Page 3 was the summary, which I have shown here. So it shows you management decision, providing advice, and then a comparison with your actual prescribing. The last page is various calculations and tips on how to improve compliance. So for their audits, again, self-selected patients show comparing your management advice and antibiotic choice with tips on how to improve. As I said, self-selected patients could leave scope for a bit of manipulation. There was no external feedback or peer comparison because it was paper-based, and it used, of course, the UK guidelines, so less transferable here. Lastly, the CDC site, they call that the core elements of outpatient antibiotic stewardship. This is the front page of it, and you can see a little bit down the front page there are the core elements and resources. I'll just zoom in on those now. So this is the core elements page, and you can see I've circled the MMWR core elements of antimicrobial or outpatient antibiotic stewardship. That's the journal article. That's got everything in a journal style format. Underneath that, there are the core elements, is made into a more reader-friendly, accessible format. So the journal article is basically been broken up into these other parts. And the only parts I'm going to look at today are that core elements in the reader-friendly part and the checklist for clinicians. And then further down, you can see the resources are the print materials. I'll look at those as well. But you can see there is other information on the website as well. So they're core elements in the reader-friendly version. On the right-hand side, you can see the index. So box 2 has some initial steps. So if you're starting to think about antimicrobial stewardship, there are some strategies there. Identify high priority conditions, identify barriers, and establish standards. But their core elements right at the bottom are commitment, action for policy and practice, what they call tracking and reporting, and today I have called audit and feedback, same thing. And lastly, education and expertise. So going into their checklist for their 4 core things. So the audit and reporting is their tracking and reporting. And the only thing they really suggest is, do you monitor at least one aspect of antibiotic prescribing? If so, which one? Do you self-evaluate your antibiotic prescribing practices, and do you participate in continuing medical education? So a lot less specific, much more general than the ones we've looked at. And under education and expertise, do you provide education to patients? That's coming into our patient leaflets, which I'll look at next. So there's stewardship. I called this more of a stewardship audit rather than an audit and feedback of your actual prescribing. But on the other hand, I thought it could be useful for a GP doing some quality improvement activities as to where to start, say for a plan activity that GPs may be doing, or establishing your antimicrobial stewardship program. If you click on the link in the CDC site to the print materials, it takes you to the patient leaflet site. At the top is a brochure called Antibiotics Aren't Always the Answer. And they have 7 languages available for all of their brochures. And on the page down at the bottom, you can see on the right-hand side, I've pointed to what they call prescription pads, which today I've called the patient leaflets. So they just have different names for what I'm calling leaflets today. So looking at a couple of the leaflets, they have a range of them. I think probably most GPs would need more than one leaflet for each patient. So here are 3 that I've selected. At the left-hand side is the Antibiotics Aren't Always the Answer brochure. This one's sort of what I call the glossy anti-pharma brochure in a way. For the patient who comes in demanding antibiotics, I thought it might be good for that, or perhaps even for leaving at aged care homes, for instance, to try and explain antibiotics aren't always the answer. So I thought it could have some uses, but it doesn't include any of my other checklist points. For those, you need to go to what they call their prescription pads. One is watchful waiting, which we probably call delayed prescribing maybe, and another one is symptom relief for viral illness. So looking at our criteria, it does not include duration of illness or what to expect. It does include self-management strategies on both of them. Very basic safety netting compared with the other 2. Basically, if you feel no better, no further action. If you feel better, no further action is necessary. If you do not feel better or experience new symptoms without specifying what they are, then call your health professional. So it does not include any red flag signs or symptoms. So quite basic there. So in summary, they had 7 languages, included self-management, very basic safety netting, no information on duration of illness or what to expect. You may need more than one of those leaflets. And as I mentioned before, antibiotics aren't always the answer. A leaflet is one that could perhaps be put in a waiting room, aged care service, and so on, or explained with your patient who's actually demanding antibiotics. So it may be useful there. So in conclusion, our Australian government website that's new is a really good place to start. It has lots of information and Australian resources. I couldn't find on our website dates for review. I couldn't find information on whether it was going to be expanded. I did wonder if it was perhaps a lot of clicks. As you click on a link, it takes you to that page on that page. So to get back to the site, you have to keep going back or remember to right click, go to a new page. I thought the RAC, the Royal College of General Practitioners UK Target Toolkit was quite good as well, and quite well laid out. So was the CDC core elements. For audit and prescribing, I felt we really couldn't go past our very own NPS website for those audits. The disadvantages of the Medicine Insight, antibiotics are only one part of their remit, and it is a voluntary opt-in program. The CPD, its biggest drawback is its self-selected patients that you are auditing. The leaflets, I thought the Australian Commission leaflets were good. They were the only ones, as I mentioned, that discussed the benefits and harms of antibiotics, but I suspect we have a need for more languages and conditions. The NPS ones were online only, would be accessible by patients at home. Didn't seem to be downloadable though, so probably of less use for the GP in the GP surgery, but they did include what to expect during the illness. They were the only ones to include that one. But for languages, you would have to return to the UK Target Toolkit, and our Australian ones seem to only be in English. That was all I could find. And finally, I just want to point out the limitations of today's talk. It has been a whirlwind tour of a very limited aspect of these huge websites of information. But for a GP who's wanting to start and reduce antibiotic prescribing today, it's a very good place to start. And perhaps even the glossy brochure, I'm seeing some vets in the audience, could even be used in the veterinary surgery as well for patients, so that they're consistently getting the same message, whether they attend with their pet, their child, or themselves. All right, so thank you for that. Are there any questions?
Thanks, Lesley. I guess it's a fairly broad just in your general kind of thoughts, they do tend to concentrate particularly on upper respiratory tract infections.
Yes.
Do they dabble a little bit new to you? I think they're missing just hitting the target, which is the easiest target, and kind of ignoring the ones which are harder? Or do you think they should be kind of going into UTIs, so tract infections, cellulitis, skin soft tissue infections, which we know are also very badly prescribed and used antibiotics?
Okay, I'll just repeat the question in case anyone didn't hear that. We've concentrated on respiratory tract infections. The question was, should we include more on urinary tract and other conditions which we know are also not well prescribed? So first of all, yes, respiratory tract infections are the number one unnecessary prescribing. As I said, we know 60% of patients with an acute respiratory tract infection get antibiotics, and most of that is unnecessary. So that's the number one low-hanging fruit to target and pick off. Yes. Moving on to urinary tract infection, you can see that in the target UK one, they have worked on urinary tract infection. I would strongly suggest that Australia looks at that as well, because that is also an area ripe for improvements as well. And of course, there are other conditions. Again, it takes time to develop all of these resources and to make sure they are evidence-based and referenced. But yes, there is definitely a need for many more of these leaflets, strategies, and so on. Yeah.
Just have an online question.
Okay, we've got online questions. Just a moment. Okay, what would you say about the ease of access through the websites in Australia? So for an Australian GP, well, when I was going through the websites, I found the Australian government website quite easy to access. I didn't have any problems. I did find, though, clicking on the links, as I mentioned, the pages opened on that page. So if you wanted to go back and look at other resources, you had to keep clicking back and back and back, depending on how far you'd gone in the other sites. Or you would have to remember to right-click open in a new page so that you had the Australian website there. The target one was very easy. You saw the headings and the plus signs. You just literally clicked on the plus and everything dropped down. It was there all on the one page, and you clicked on it and it just opened up and directly downloadable from there. So those leaflets directly downloaded. You could select your language, it downloaded. So easy. CDC, a few more clicks, but not to the extent of the Australian one. So the Australian one was probably the most cumbersome to get through, and then the easiest was the target one. So we've got some more questions from the floor.
Yeah, Lesley. So you're talking about when they're on the website, but that's on the basis that they know that that's the website to look at. Have you looked at how a GP would find, like, what a Google search would bring up? Like, would it take them, would that come up as a first sort of
the target
source?
Yeah, so sorry, the question is, would a Google search take you to these sites? I used Google to find target. Yeah, it comes up, it's straight away at the top. The CDC core elements, I think from memory, yes, it was fairly high up. I haven't actually Googled for the Australian one, to be honest.
Yeah, I would agree with that. I think it's very strange that this is kind of posted on the government website and not on the college website where the GPs are most likely to be going to. And of course, the government website covers everything, but you know, that's not the go-to place, I guess, for antibiotic information for most users. Would you agree? Or?
Yes, so yes, it's, as we say, it's hosted on the one government site, which seems to host all of the antimicrobial stewardship area. I mean, it is titled for antimicrobial stewardship. So yes, it's not an intuitive place for a GP to go to, as against going to their college website. But whether that's a case of just publicising, everything's going to be available on this one website, because there is no other place for a GP to go to get that information in Australia. There is nothing as such on the equivalent college website for Australia that there is on the English one, for instance. Yeah. Sorry.
It'll be interesting to find out from GPs what workflow issues, how workflow issues impact on their use of these bias measurements. Like, do they feel comfortable stopping a conversation during a consultation and referring to the GPs? Do they perceive that sort of handing out for the leaflet?
Yeah. So the question's about the GP perceptions of the leaflets. These leaflets are very new in Australia. Australian GPs haven't had a lot of practice of using these from the point of view of antibiotics. So that is something that I will hopefully be looking at in the course of my PhD studies, and definitely will be very interested in GPs' feedback on these, how easy it is to incorporate, what features they want in their leaflets, and how they'd like them designed, and what do they want, more than one, different ones like the CDC ones, or what? Yes, so very good point. And there's another online question. Do you think there needs to be a dedicated site for GPs? Well, I'm sure a GP would love to have a dedicated site. That's almost a give me, isn't it? Yes, I think every profession would like to be able to go to, whether it be their own college or their own site. I'm a GP, this is where all my GP information is, and I can find related areas all in the one area. Yes, I think they would, and that is something I will be asking GPs in my interview sessions. Yeah.
I guess I was just wondering whether the college website it doesn't have any links to anywhere outside the college website, because it could link to this fairly readily.
It could link. Look, I am not a GP, so I don't have access to the full college site. I can only comment as an outsider at what is publicly available. I did not see any links on what I could access to these sites. However, that does not mean to say that a GP couldn't have access, but I'm not aware of any such links. But that doesn't mean to say there may not be one, but I'm not aware of any. So, any other questions? No?
Okay, thank you very much, Lesley. Our next speaker is Courtney Ierano, and she's another PhD student of NCAS, and she'll be discussing surgical antimicrobial prophylaxis.
Thanks, Arjun. Good morning, everyone. So I'll be talking about antibiotic prescribing in the hospital setting, specifically looking at surgical prophylaxis. We're calling this a preliminary analysis of the SNAPS data set, and I'll explain what SNAPS is in the following slides. But before that, I'd like to acknowledge my supervisors, Karen, Trisha, Darshini and Caroline, and also Rod James from NCAS, who's helped me with a lot of the data cleaning, and also to acknowledge that the SNAPS has been funded by the Commission on Safety and Quality in Healthcare, the Australian Government's Department of Health, NCAS guidance, and my scholarships funded by University of Melbourne. So why surgical prophylaxis in the first place? So SAP, surgical antibiotic prophylaxis. From our NAPS surveys, the National Antibiotic Prescribing Survey, in the couple of years that we've run the report, surgical prophylaxis has been the most common indication for antimicrobial use in the hospital setting. And not only has it been the most commonly prescribed, it also had the highest rate of inappropriate use at 43.1%. So further from the NAPS, the surgical NAPS was then developed, and from the analysis that I've done, I guess the aim of the analysis is to describe, well, what is actually happening in Australia with surgical prophylaxis prescribing, a more detailed look, and from that being able to identify these areas of inappropriateness, and that will hopefully inform targets and interventions for AMS. In terms of the method, so the surgical NAPS
has run over 2016, 2017, and the data I've got is up until the 30th of June 2018. And so it's from any hospital that participated and contributed to the SNAPs over that 2.5-year period. In terms of design, it's a retrospective cross-sectional period prevalence study. However, the design was up to our hospital users. So if they wanted to audit a particular ward over a day, over a month, we left that up to the users to give them a bit more flexibility to support the use of SNAPs. Just important to note some key definitions. So procedural prophylaxis includes antibiotics administered prior to or during, so pre-op or intraoperative. Post-procedural, any doses after the incision has been closed. We also captured existing antimicrobial therapy. So at the point of auditing that patient, they may have already been on antibiotics for whatever other reason, and that might have influenced the choice of surgical prophylaxis. Surgical episode, so that was an encounter of the patient. So with every surgical episode, we would capture those 3 requirements: a procedural, post-procedural, or existing. And it was whether or not that they had all 3 of those antibiotics prescribed. They might not have had any of those 3 options prescribed, or so forth. And then what's unique to SNAPs and NAPs is this term called appropriateness or inappropriateness. So we, in the references to our assessors, there's an appropriateness assessment guide. And when we refer to appropriateness, it's what's been considered an optimal or adequate prescription, and inappropriateness is considered suboptimal or inadequate prescriptions. In terms of overall results, across that 2.5-year period, we ended up with 19,725 antimicrobial prescriptions across almost 13,000 surgical episodes. From that, over half were procedural doses, and then 23.6% were post-procedural doses that were prescribed for surgical prophylaxis only. So that's why that doesn't equal the full 100%. When we look at post-procedural doses, we also captured data that looked at treatment, so treatment of infection, or those that weren't accessible. So that sort of fills in the total 100% there. In terms of capturing data across Australia, over 60% were from public healthcare facilities, and again, 64% from major cities, and the largest contributors being New South Wales and Victoria. In terms of looking at public and private again, when we look at surgical episodes, the second main column is where at least one antimicrobial was prescribed, and that was occurring at a higher rate in our private sector, whether it's for procedural and post-procedural, and I've marked those in red. And then in terms of inappropriate doses, again, high rates of inappropriateness for procedural and post-procedural and across public and private, but more so post-procedurally and more so slightly in the private sector. When we're looking at our patient and surgical procedure details, relatively similar proportions of males and females. Initial surgeries accounted for majority of the data set at 95.6%, similar with elective surgeries. And the SNAPs also captured some other key components of the procedure, and prosthesis and removal, whether it was a removal or insertion of a prosthesis, was included in almost 30% of all surgical procedures. Timing of the first incision is an important measure for assessing appropriateness in relation to whether the dose was administered at an appropriate time. And this was only documented in 65.6% of cases. So again, identifying a room for improvement there, and also making it a bit more difficult to assess the appropriateness of timing when we don't have that incision documented. This big image here is looking at the overall appropriateness of the surgical episodes. So when we look at the surgical episode, they could have been prescribed multiple procedural, post-procedural doses. If one of those was considered inappropriate, then that sort of made the whole episode inappropriate. Looking at this image as well, we're also looking at when doses were prescribed and when they weren't prescribed. So if an antibiotic wasn't prescribed, that actually might have been appropriate. So we're not purely looking at inappropriate doses here, we're looking at the whole episode of care. So red is highlighting inappropriate and green appropriate. So if you look right down at the bottom for gastrointestinal endoscopic procedures, antibiotics generally aren't indicated. So in a lot of those cases, you can see that they weren't given and it was appropriate. When we look right up at the top, we're looking at cardiac surgery, and nearly 60% of all surgical episodes were considered inappropriate in terms of their antibiotic use. Also to highlight, orthopedics is third most common, but if you look at actually the numbers, there's 1,400 for both inappropriate and appropriate, which is a large amount of data. So other procedure groups have smaller numbers, so it's sort of in comparison. We're looking at proportions of the total episodes, but obviously it's biased to which craft groups were audited in each hospital audit. Looking specifically at doses, so the last slide was looking at the surgical episode. Again, pretty consistent to the original NAPS report about inappropriate use of surgical prophylaxis. But what SNAPS does, it looks at procedural and post-procedural separately, and you can see that post-procedural total doses had a slightly higher rate of inappropriateness, and that was even more so when we looked at doses for prophylaxis and compared to treatment doses. Looking at procedural, initial and repeat doses, not too much of a difference there as well. These graphs are looking at the reasons for inappropriateness. So looking at procedural on the left and post-procedural on the right. And this is only looking at the data when antibiotics were required by guidelines. So I guess the first thing is, if they're not indicated at all, then they're not appropriate. So if that's the case, then you wouldn't be looking at all these other factors. So with the SNAPS, we can filter it down to looking at the data when a procedural or post-procedural dose was required by guidelines but was somehow given inappropriately. And when we look to the left at the procedural doses, you can see timing was the most common reason for inappropriateness, so the blue, followed by dosing and too broad of a spectrum of the antimicrobial choice. When we look across to post-procedural doses, duration was the most common reason, followed by incorrect dose or frequency. It's important to note that timing was only applicable for procedural doses and duration for post-procedural as well, and it's why they don't cross over into either column. Things like allergy, micro mismatch, and incorrect route were less frequent but still occurring. In terms of guideline compliance, again with the SNAP, so we've been able to filter this as measuring guideline compliance for when there were actually guidelines applicable. So if you look at the data in general, there might be instances where it was directed therapy and guidelines didn't apply, or there weren't guidelines available. So this is purely looking at data that had either therapeutic guidelines addressed that procedure, or there were local guidelines in place. And you can see that, again, non-compliance procedurally to the left at 41.2%, not ideal, but this was occurring at a greater rate in post-procedural doses at 66.3% as well. In terms of common antimicrobials, so the top column is procedural and the bottom purple section is post-procedural. Cefazolin, the most commonly prescribed antimicrobial, procedural and post-procedural, and in compared to the other antibiotics, had a not too bad rate of inappropriateness, still 54.7% post-procedurally. which would make sense because more often than not, post-procedurally antibiotics aren't indicated. Procedurally, even at a rate of 35.5% is concerning because it is the first line therapy. So we want to know what's going wrong there for it to be considered inappropriate. And your broader spectrum antibiotics like vancomycin and ceftriaxone had higher rates of inappropriateness there. Looking at post-procedurally, that all the ceflexin, which is an oral antibiotic, so 86% inappropriateness, which we would make sense as we know that, again, antibiotics aren't indicated post-procedurally as an oral tail. Chloramphenicol, of those 245 doses, I'm pretty sure 99% of those were topical. I think we worked out that they were all topical. And again, 46.9% inappropriate. A deep dive into that, it wasn't that the rest were appropriate, it was more that they were considered not accessible. So again, another area to look into use as topical prophylaxis isn't commonly indicated for surgical site prevention as well. And I guess it's just highlighting that overall, if you can see that, well, the last column, the rate of inappropriateness is quite high for all of those. This table is looking at procedural doses, but specifically looking at the surgical craft groups. So you can see under surgical episodes, the top couple of procedures account for a large proportion of all their craft groups captured across the SNAPs. And then again, the next section is the proportion of antibiotics prescribed per surgical episode. So I guess big players of antimicrobial use are your orthopedics, abdominal surgery, obstetrics, cardiac, and breast surgery. And I've highlighted those in red. The next section across is looking at total doses prescribed, which is not always reflective of the surgical episodes. And again, those top procedures there, orthopedics, abdominal, plastic, and urology, were most commonly implicated procedures with antibiotic use. But then if we look further across, in terms of inappropriateness, it doesn't always reflect the most commonly audited procedures. So the inappropriateness was higher for a different range of antibiotics. So we are commonly targeting orthopedic surgeons in our audits because it's obviously a higher volume of surgeries in our hospitals and easily to measure, and they're also targeted in other audits too. But in terms of inappropriateness, they were pretty reasonable with 34.3%, whereas other things like dentoalveolar surgery down the bottom there I've marked at 74.9%. So it's just highlighting that with the SNAPs we can identify different procedures using antibiotics inappropriately and again informing different targets for AMS interventions. Post-procedurally, again, you can see it's quite varied. So again, whilst those, like the first column here highlights the orthopedics, abdominal, plastics as the most commonly audited surgical episodes, the high prescribers were again different. So if you're looking in that second column, cardiac, ophthalmology, even thoracics had a greater proportion of antibiotic prescribing per episode. And again, that inappropriateness, looking at breast surgery and dentoalveolar, again, at over 70% inappropriate. And if you look at that final column at the end as well, there's, I think, 15 procedure groups there, and I think it's about 9 of those 15 already had greater than 50% rates of inappropriateness. In terms of overall duration, so 99.6%, so nearly all of that data that we've captured for post-procedural surgical prophylaxis doses had a duration between 0 to 21. And you can see it spikes at the 1 day mark between 0 and 2. And basically we can't, based on the data, it is a limitation. We can't differentiate whether something was given within 0 to 24 or between 0 to 24, or they say within a day if it was just over that 24-hour mark and if it pushed over to 48. But basically you can see that it spikes at that point, and then spikes again at that 5 to 6, 7 day mark, which is sort of indicative of that oral tail, or that perception of a week of antibiotics after a procedure is sort of a stock standard practice. I guess looking at this, we would then want to try and identify which craft groups are then prescribing at this further down spectrum with the prolonged duration. And I have done that. So I found from those, there was 8 of those 15 procedural groups where greater than 50% of their surgical prophylaxis doses were greater than 48 hours. And again, highlighting dentoalveolar, head and neck, plastic reconstructives as greater than 70%. In terms of limitations of the data I've presented today, so participation in SNAPS is voluntary. The sampling and selection bias, as I've mentioned, because they do have the flexibility to audit where they want, for however long they want. We also have the option to collect outcome data, so at the 30-day mark after the antibiotics had been given. So that was also not a mandatory component. Hopefully when we get more people completing that section, though, we'll have a bit more data and trying to identify any impacts from inappropriate use and how that relates to actual presentation of surgical site infections or consequences of antibiotic use, such as multi-drug resistant organisms and Clostridium difficile. We talk about this concept of appropriateness and inappropriateness, but our assessments, of course, are not entirely objective. We do give the guide to support and try to provide some consistency to our assessments, but at the end of the day is based upon whoever has completed the audit at the hospital site. As I mentioned, there was insufficient data at the moment on clinical outcomes, but hopefully over time we'll get some more. There is always incomplete or inaccurate data records, which has been good from a learning perspective from the SNAPs, and as we clean the data, so then when we feed back for SNAPs in the years to come, what fields need to be mandatory, or having our assessors confirming dates and making sure that it actually calculates how many days of antibiotics. It's so easy for someone to put in the wrong year or the wrong month, and then it changes the antibiotic data from, instead of being 2 days to 20 days and things like that as well. And also, when there was inappropriate prescribing, or there were things like a microbiology mismatch, that data to explain why or justify why wasn't always there. So again, we can then feed that back to our SNAPS developers as things to add in or mandate in the development of SNAPS to help its progression over the years to come. I guess some key points from all of this that, well, we're aware surgical prophylaxis is prescribed inappropriately. We can see it's at a higher rate of inappropriateness amongst our post-procedural doses. So in terms of priorities, that might be more of an emphasis or a target for stewardship. The reasons for inappropriateness differed according to procedural and post-procedural. So again, we've got 2 separate issues with 2 separate problems, so we can't just bundle it all up in one solution. And again, those rates of inappropriateness also differ to the craft groups, the antibiotic of choice, and again, in the public and private sector. So what is good about the SNAPS is that we can deep dive and look into this data a bit further and provide more guidance and information to our craft groups as to where the perceived problems are. And I guess we want to hear from them too, so we can work together to address this issue. So I guess this is just the tip of the iceberg. There's a lot more work to come. And like I said, we, after this analysis, I intend, as part of my PhD, to deep dive further into looking at specifically at different craft groups or the big players of inappropriate antimicrobial use according to our SNAPS data, looking at timing. So the World Health Organization, CDC, have published guidelines in the last year or so advocating for single dose and within 120 minutes of timing. So we want to see if there has been a change in practice over time in relation to those guidelines. What's good with SNAPS in its longitudinal nature is the therapeutic guidelines are updating, hopefully by the end of this year or next year. So we'll have plenty of data before and after for years to come, so we can compare the impact of those guidelines if there's any significant changes made there too. Yeah, so a lot of information to take in, but I'll leave the floor for some questions. Yes, Robin?
Thanks, Courtney. Your data is showing that for elective surgeries, and for these patients, it's usually initial surgery, that there's a big, that there's a lot of, there are a lot of doses given at the wrong time during the procedural aspect of the data collection. That's obviously what we're seeing. With the focus groups that you've been running, has there been any commentary from the anaesthetists or surgeons about why they feel that, given that these are elective patients, that there's such a delay in getting them the antibiotics at the right time, or that antibiotics are not being given at the right time? Any commentary around that? And the second part of my question is, has there been any commentary from them to say that if they were more confident that the antibiotics are given appropriately upfront, that they might then reduce the duration of antibiotics post-procedurally?
Yeah. Yeah. So I guess the first question was, well, as part of my PhD, I'm also running qualitative focus groups with a range of surgical craft groups and anaesthetists about surgical prophylaxis use. And the question was in relation to, have I heard any comments about their issues with the administration and timing and how their perceptions, whether it's done appropriately or not. It's sort of come up that most of them feel that it's definitely given within the 120 minutes according to the World Health Organization. So I guess our SNAPS data could possibly be that it's harder to accurately capture that information because incision times are not documented. And it's come up a lot from the focus groups that the anaesthetic record and the report, a lot of it is done retrospectively, so not always accurate and a true reflection. So they're generally optimistic that it's done well. If anything, they're more concerned that it's given too close to incision. So the World Health Organization's 2016 guidelines said in that 120 minutes, therapeutic guidelines are saying ideally within 30 minutes before. And I guess the anaesthetists were more concerned that they see the patient, they'll probably give it maybe 10, 15 minutes before they see the patient. So it's more a workflow issue. And also, I guess, with things like vancomycin and things like that, which has to have a prolonged administration time, they're more concerned that they're administering it too soon to the surgery, that it's not reaching peak concentration at then. And even when that has been sort of said, it's, well, it's too late now. It's better to give it close to incision than to not give it at all. I think it's more of a timing, a workflow issue as well. And I guess they discuss it in timeout as part of the surgical procedure, but more often than not, it's already given at that point. So it's sort of come up that, yeah, there's a lot of other underlying factors influencing that. But they seem pretty overall optimistic that they were okay with giving it. They were confident in their ability to give it at an appropriate time. And into your second question was, did they think that giving it at an appropriate time made them feel that they didn't need to give it post-procedural doses? That actually hasn't really come up. They didn't think that giving it appropriately at the start didn't mean that they didn't need to give it at the end. It's sort of many other cultural issues underlying that. Now we've got some questions from Kaz online. Oh.
Okay, we better leave it there as it's 9:30. So thank you for our two presenters, two excellent talks and very thought-provoking. Hopefully we can get some of this information back to GPs and surgeons. But anyway, thank you very much, and we'll see you again in a month's time. Thank you.